response?
First reports with fire. I need a helicopter for an accident.
Okay.
It'd be M15 and Russell Road in Bay County.
I need a big cover up and take out.
That's Airport 2, go ahead.
Bay County, Merritt Township.
Bay County, Merritt Township, stand by.
Copy, what is it? Portables 2, 3, and 4. 2, 3, and 4, you are 3 for Bay County, Merritt Township. I have coordinates when you're ready.
All portables acknowledge scramble, and I'm ready to copy.
All 4 acknowledged.
Flight 2 is lifting with 3 souls on board. Shows 8.5 miles, giving 5 minutes en route. Carrying 1 hour and 50 minutes of fuel.
White Carol, so you're going to skip us with 5 fills, 8.5 miles, 5-minute ETA. We'll plus 5 here on the fuel.
We're down safe and sound in the L3.
Copy, I'll show you skip. Yeah.
That'll be 0.4 on the flight time, 0.4.
Copy, 0.4.
When the emergency department gets notification that a patient is coming in to be seen as a trauma patient, we generally receive a phone call from EMS.
All right, Sam, we're at the hospital. We're going to get you going inside, okay?
We rely a lot on our pre-hospital folks, our MMR, our EMS individuals when they're evaluating. What takes the longest procedurally is a motor vehicle accident with a patient who's had multiple injuries. They've had a large accident, a lot of damage to their vehicle, and they're coming in and they have blood pressure issues, question of bleeding, things like that. These become high-level traumas for us.
How's your pain level right now? On a scale from 1 to 10, 10 being the worst. 10?
We differentiate traumas into 3 different categories. We have a level 1, a level 2, and we have a level consult.
When the patient arrives, the trauma team is already assembled. Our trauma team consists of radiology, lab, respiratory therapy, a member of the trauma service, trauma surgeon, one of our trauma PAs who works here will come down as well. They kind of announce
This is Sam, 24-year-old female involved in MVA today. Car was going approximately 55 to 60 miles an hour.
I'm going to drop your butt a little bit. Just a little. Alright, Sam, we're going to move
Moderate
you over,
damage
okay?
to the rear of the vehicle. It was rear-ended.
Just keep your arms in and we'll do all the work. Alright, drop three.
The first thing we do is we move the patient from the cot to our stretcher. An important piece of this is that we always let the paramedics be the only one who are talking when they hit the room. We need to know exactly what they've seen at the accident site, exactly what they've seen during their initial assessment of the patient, and what they've done to try to help that patient get better. At that point, we take over. There's a scribe in the room, a nurse who stands back and doesn't necessarily participate in patient care, but records everything that's going on, including assessments, interventions, lab values, whatever comes through. They are able to record all that, so we have documentation of what we're doing to help. All trauma patients, just like with any other patient in the room, start with ABCs. We make sure the patient has an airway, we make sure they're breathing, we make sure they have a pulse. And then we kind of move on from there. We look for the most grievous injuries first. Meanwhile, there's about 6 or 7 people at this patient. There's a doctor at the head generally leading the charge in terms of assessment. The nurses are busy making sure the IVs are established and running. Somebody's in to draw blood. We're getting the patient prepared for x-rays. So it can be a fairly overwhelming experience and a time for the patient only because there is so much going on around them and they've just come from a fairly significant event. We then work on medicating the patient if we need to, for pain, for whatever else they have going on, and then we get ready to send them over to CAT scan.
Playing mostly a back pain, no chest and belly pain.
Okay.
Pain back there.
center's service. Right?
Okay.
2 plus pistol pulse.
Okay.
Basically. And what the ER does is we have criteria that we set up through our trauma program. Level 1 traumas will be the most critical patient. They'll be somebody that we would consider very unstable, whether it's their blood pressure, their pulse, they're not breathing well, they're on a ventilator, they have certain types of injuries that we consider high-level injuries that are very critical, that we know can be something closer towards somebody either living or dying. And then we go on to our level 2 traumas, which are not as critical as our level 1s, but still in the same note, there are mechanisms or there are injuries that we know through years of evaluation with the National Trauma Database of injuries that can get worse if they're not identified right away. We consider these level 2 traumas, which don't need immediate attention, but they still need resources at the patient's bedside so that initial workup is done. And then finally, we have a third level that we consider a trauma consult, somebody that maybe walks into the emergency department or somebody that was in a motor vehicle accident, but they don't really have many complaints, but the mechanism of the injury led the ambulances to bring them in, and they're not considered high priority, but they still need evaluated. They would get what we call a trauma consult, and that would initiate a different level of resources. So it's the level 1 trauma patients that really take a lot of resources. When we call a level 1 alert, we expect not only the ER physicians and all the resources that we need, lab, blood, x-ray, all the radiology folks to clear a scanner for us because they know that we're probably going to come there. But we need an expert trauma surgeon in that room within 15 minutes.
My role as a trauma surgeon is to help in the assessment of the patient when they come into the emergency room and determine if there's anything that I need to do to help preserve that patient's life. Are there any life-saving maneuvers or procedures that need to be done either here or up in the operating room? And that in order to do that, we obviously look at their labs, look at their vitals, we look at imaging studies, and try to make as quick of an assessment as possible to determine if there's something that needs to be done immediately or if there's something that needs to be done in a delayed fashion. And we follow that patient when they get admitted to the hospital, and we monitor their entire course in the hospital and manage all their medical and surgical issues while they're here in the hospital.
The other thing that needs to happen is that we need to make sure that the team members arrive usually within 15 to 20 minutes of when the call is made, of course determining where the patient is located and how far they're coming from.
There's a lot of urgency noted, and this could be 2 in the morning, and the trauma surgeon has to leave their home and get in within a certain period of time. You have a service that's evaluating with the emergency department folks, and you're doing a head-to-toe evaluation in the shortest period of time.
How about there? Pain there?
Okay. Pelvis.
Yep. Pain here? That's good. How about down this side? Okay. You feel me touching everywhere?
Yes.
All right, we got two IVs in her yet?
Did you get labs, Margaret? Yep.
All right,
Should we roll her?
let's get X-ray in here, and then we'll get her over the
So you can figure out what's causing the problems and what is more life-threatening versus what is more non-life-threatening. And the initial workup can take anywhere from 15 minutes to up to an hour, depending on what test you need, CT scans, whatever you need.
So this trauma patient comes in and she's involved in some sort of motor vehicle crash. And I guess the most important thing from an emergency standpoint is to assess her airway, make sure she's breathing okay, her circulation, vital signs, blood pressure, heart rate, things like that. We do an initial survey, sort of a head-to-toe, quick look at the patient, see if there's any major signs of trauma, listen to her heart and lungs, see if there's any deformities of the chest, any abdominal tenderness, any pelvic instability, any major long bone fractures, the extremities, legs, arms. Roll the patient, assess their back. That's our initial kind of head-to-toe quick survey of a trauma patient. Then after we've kind of assessed that and made sure there's nothing, you know, grossly abnormal, then we kind of fine-tune it, figure out, you know, where any local injury would be, you know, if they've got a wrist injury or a knee or an ankle, something a little less important, but still you don't want to miss it. You know, so then we're looking at blood work, you know, trauma labs, getting their hemoglobin, make sure they're not pregnant, alcohol involved, drug use involved, things like that. If they've had any loss of consciousness, we're looking at CTs of the head to look for brain injury, cervical spine injury, and also if they've been in a motor vehicle crash, we're looking at their chest to make sure there's no, you know, injury to the great vessels in the chest. Looking at a CAT scan of their belly to make sure there's no organ injury, liver, spleen, that sort of thing. So that's sort of my initial emergency department thought process when I see a trauma patient coming in.
Whatever you need, and then after that, there's still other survey and other things that need to be evaluated for the patients before you might even get a chance to even see the family. It could be a few hours before you get a chance to even have the family come back and see the patient.
At the time of a traumatic event, there's a multiplicity of things going on. First of all, disbelief by the family member that their loved one has been injured. There'll be summons to the hospital, possibly by a phone call, or even the police in some circumstances. But most likely it'll be a phone call, especially with today's technology. You may get notified by a neighbor, bystander, or relative, or you may get a call from someone at the hospital, the emergency department. It could be one of the secretaries or one of the nurses, and confirming or telling you that your loved one has been brought into the emergency department because of a traumatic event, such as a car accident.
Hello, are you Samantha's family? We're going to take you back into the family waiting room right now, okay? Come on this way.
Now, when you arrive to the emergency department or arrive at the hospital, you may be greeted by someone. Most likely it may be one of the emergency department unit secretaries, one of the nursing assistants, or one of the registered nurses, or it could be someone from spiritual services or social work. And most of the time they will greet you and take you to a private room if that's available, so you can be with your other family members. And also usually you'll have access to a phone there as well. Now, of course, you're upset. You don't have a lot of information in most circumstances. And usually the staff at the hospital may have the most up-to-date information as to what happened up to that point. And they may not have all the information about the car accident itself. They may have only gotten some information from the paramedics, and the police sometimes will have more detailed information. But all you're really concerned with is your loved one. How are they doing? How serious is this? You know, could they die? Will they be disabled? And so on and so forth. And then, you know, where were they going? Were there other people in the car? Are they okay? And the list just goes on and on for you.
Right here on the left. We'll have you make yourselves comfortable and he'll be right in, okay?
Didn't intubate her, obviously. Yeah, call the level 1.
Yep, she's good. I gave her medication and gave her medication. She's good.
I'm back in case. Trauma surgeon. Your mother? Yeah. Sister?
Chaplain Bill around here. What is your name, please? Judy? And Noel. Okay.
I want to talk to you about crash, so she was in a pretty bad car crash. It looked like she was in a rollover motor vehicle collision. When she came into us, she looked like she was doing all right. We sent her to the CAT scanner. Did show some significant injuries. She has a pretty significant bleed in her brain, actually, and she also lacerated her spleen. She essentially injured her spleen, and she's bleeding from her spleen. She was okay when she came in, but now her blood pressure is starting to become compromised, and for that, I think I'm going to have to rush her to the operating room for an operation to remove her spleen. Any other injuries that I find, I will take care of at the time, and we'll give you an update as soon as possible. But it's not something I can wait on. You have any questions for me? Okay. Now she is intubated at this point. We had to end up putting her on the breathing machine just for her safety and monitoring, and hopefully we'll be able to take her off that breathing machine soon after the operation. But
will they be able to see her before surgery?
we'll have you come back and see her just momentarily before I rush her out, but we don't have a lot of time to delay, so. Okay.
Could you tell me what happened? I'm not sure at all what happened. I knew there was an accident of some kind.
Yes, I'm uncertain also on what happened. Just we received a call from the police, and then they told us where to meet the ambulance at, and I'm not sure. I really don't know much about the accident.
When we get called to a trauma, we really never know what to expect. It may be something very critical. There may already have been a death. Most of the time, the patient is injured or wounded in some way. And our first line of contact is with the family, generally speaking. So when I meet the family, I introduce myself and try to get them to talk a little bit about themselves. And then I ask, how may I be of help? How may I be of help? I try to let them tell me what that means rather than bring my presuppositions to the scenario. They're hurting pretty badly at that point. My primary job is to provide spiritual and emotional support. That means being willing above all to listen. And I'm not an advice giver. I'm not there to fix their problems. In fact, I can't do that even if I wanted to. So my task is to walk with them for a while on this portion of their life journey, and during this crisis is to exercise what is sometimes called a ministry of presence. They won't remember in weeks to come what I said to them in ER, but they will remember the fact that I was there, and I did walk with them, I was with them, and I represented the presence of God to try to bring solace and comfort to their pain and to their hurt. So prayer is a big part of it. Sometimes we use the Maslowian model of the hierarchy of needs. What I mean by that is Maslow talked about making certain things were present so that a person may achieve maximum health. One is a physiological need, so I may order a tray of cookies and coffee, for example, to help them. They may be starving, they may not have eaten all day, they may be sleep deprived. So we try to meet some of their physiological needs. Safety needs come next. We need to reassure them that they are safe here. Especially if there's been a shooting, they are safe and secure in this environment. And the third is social affiliation. Often I will call the pastor or other members of the faith community they belong to, if that's appropriate, and bring them in for additional support. And then finally, there's a term called self-actualization, where they begin to experience self-empowerment and begin to talk to God on their own terms. They may be angry, they may be upset, they may be at peace, and who knows. All of that they can bring to God and expect that He will be there for them. I try to facilitate that kind of movement with prayer and some spiritual guidance. So it's a multifaceted, multifactorial work. Again, I never know what to expect, so I'm just ask God to help me as I walk into that situation to do what is best to be a maximum help.
We like the families to be in the patient rooms as quick as possible, and we make an effort to get the families into our trauma bays as quick as possible, especially our pediatric patients.
Now, there'll be a point when you'll be, brought in to see your loved one, and at that point, your most important thing is to focus on them, not all the equipment, not all the personnel that are taking care of them, but go ahead, touch your loved one. You should get some guidance by the hospital staff as to exactly what you can do and what you're going to see prior to entering the room. But really, your focus is on, the loved one and getting to see them and touch them and communicating with them in some way that you're there. Even though they may not be able to talk to you, touching and talking to them can be very comforting to them. And even though you're upset, this may help once you see them, because it helps confirm their real condition to you.
It's important for families to know that you're doing everything you can for their loved one, but understanding there's going to be certain situations where you can't have as much traffic in the trauma bay when you're trying to do life-saving maneuvers and things like that. We have a system set up in the hospital where we have individuals that will discuss with the families what's going on, and they give them routine updates so the families aren't sitting in a room all by themselves trying to figure out what's going on with whoever is there. Many times the patient's there far ahead of the families, especially our traumas that come from further away that had to be flown in. They may be 30 to 40 minutes out, so by the time they show up, they have a better idea, and we have individuals that can better explain to them what's going on, what the process is. So we do a pretty good job at getting the families involved right away. I think that they give us a lot of information. A lot of times the patients aren't able to communicate. They have a brain injury. They had to be intubated in the field, and you can't really get a history, and especially with your elderly patients, you need to know what medical problems they've had, what medicines they're on, what allergies they might be in. All of these have a part in how you take care of these patients afterwards.
It's a dynamic process. In the emergency department, initially, it's processing for acute injury that needs to be treated, and the family is made aware of those things. Particularly if they have to go to surgery, they would need to give some type of consent for that surgery. So then they'd be informed that their loved one is going to surgery for a clot that's on their brain, or a compound fracture that's a fracture where the bone is broken and is poking through the skin, those types of situations. But families are updated from time to time, but it's helpful to also generate some questions if you can. But I know you don't have any prior experience probably with this situation, so you may not know which questions to ask.
The nurses are probably the best advocates for patients, and they go around, and even the nurses that work in the ICUs and on the floors, the questions that they come up and ask the doctors are typically questions that are advocating for the patient what's the best next step for them. I think once they reach the hospital, and it's a high stress environment, the most difficult cases are your motor vehicle accidents where you've had multiple members involved in one accident, and now they've been taken to 3 different hospitals. And that is probably the most difficult situation for any family member to deal with. And the question of, where do I go first? And the answer would be obviously the closest place first, but wherever your loved ones are, they're making every effort possible to make sure they can get hold of family, that ultimately as you arrive at whatever facility, we're going to do all we can to update you and make sure that everyone involved is as close together as possible. So as a trauma center, We deal with more of this because the surrounding hospitals around us are not trauma centers. Eventually the patients are coming to us or they're going someplace else depending on their injuries. So that does become very difficult in mobilizing enough resources to get everybody as close together as possible. And we like the families to be together. We like all the family members to be in the same hospital if possible. I think it's important for those patients and it's important for the families to be able to do that. It's very stressful to get from one place to the other. Some families, that vehicle was their only means of transportation, and now they have to look for other ways to get around, and if they have to travel 30, 40 miles between places, much more difficult to do. So we're very cognizant of that, and we make every effort to make sure we're able to help them in these situations.
Okay. The measure of success as a result of caring for a motor vehicle accident, multiple trauma, when they've arrived in the emergency department and are on their way to next steps, is simply the fact the whole team has come together, and it really does look like a concert of collegial chaos when they initially come together, but the success factor is that within a very reasonable amount of time, of course, depending on what the trauma is and the nature of the injuries, that patient is on their way to whatever is necessary to stabilize and save, in most cases, save their life. That could be the OR. That could be a CT scan, which then will lead them directly to the OR. And then a coming together afterwards where the patient's family or their loved ones know what the situation is. The trauma surgeon has spoken with them. We have made arrangements for them to move to whatever the next area might be.
MPC, yes, fracture, piece of bed rest, vitals Q4 now, Q4 MPO, saline at 150, got that access in the left arm. Contact Celebi, MRI for C-spine in the AM, morphine and Zofran 4 milligrams.